to Dr. Senthil. If suppose you have a patient who has come to you with a CT report of T3N1, he also has come with MSI testing as high, what is the neo-adjuvant you will give?
So I think the optimal neo-adjuvant is not defined as of yet. There are two options for a patient like this. One is to just do dual immune checkpoint inhibitor. That means you use two drugs. Because when you use two drugs, your likelihood of clearing this tumor completely, as Bharat showed, is around 60%. And you may or may not want to go ahead with surgery. Maybe continue the immune checkpoint inhibitor for about 6 months and then stop it there. Standard would be to still offer this patient surgery, though I said that there is an option of not doing surgery also. That's one way of treating this patient. The second is to use FLOT plus an immune checkpoint inhibitor, get to surgery, finish your FLOT and do your immune checkpoint inhibitor. Whether there is any role to continuing the immune checkpoint inhibitor beyond that is a question that we really don't have answers for. So what is very clear is that this patient needs exposure to immune checkpoint inhibitor. What we are not very clear is about whether chemotherapy is necessary or not, and also whether surgery is necessary or not.
Sir, Senthil sir, so you said like FLOT is, I mean if at all the patient is not tolerable FLOT, in that case for severe type 2, type 3 lesions, do you send them for chemotherapy or chemoradiation upfront?
Good question. So I think that decision needs to be made on day one. Let's say I have a 75-year-old with a bulky GE junction tumor that's an adenocarcinoma, whom I am very sure will not be able to tolerate FLOT. Then there are two options for a patient like this. One is to just do perioperative FOLFOX rather than doing FLOT, which is what we do most of the. FOLFOX is very much tolerable. We have 90-year-olds who are taking FOLFOX, so that's an option. But if you think even FOLFOX is not an option, then I think chemoradiation is also not a great option for a patient like that, because they will tend to stutter and stagger when you reach your second or third week of chemotherapy, whether it's myelosuppression or peripheral neuropathy. But I know where you're coming from. The point is, if for some reason, if you think that your patient upfront is not a candidate for FLOT, and if it's a GE junction adenocarcinoma, cross protocol is an acceptable alternative in that situation. But wherever possible, it's predominantly chemotherapy without radiation as the perioperative treatment for adenocarcinomas of the GE junction.
Thank you.
I'll just,
one last question, if you don't mind. Again to the oncologist. This is specifically in the context of neo-adjuvant chemotherapy in resectable gastric cancer, like let's say only T3 with limited nodal disease. Sir, the proximal adenocarcinomas and distal, they're a bit different, right? Proximal is more a systemic disease, very aggressive, while distal is mostly Indian predominant, H. pylori related. So do you think in these T3N1 kind of tumors, which from the Western data we are saying that the proximal cancers require neo-adjuvant, will that thing will be applicable for the distal tumors, antropyloric tumors, which are more common in the Indian context also?
I think the question that you're asking has not been clearly addressed in the clinical trial so far. Let's leave alone whether it's proximal or distal. Do we have a trial in stomach cancer to say that neo-adjuvant therapy is superior compared to adjuvant therapy? Let's say, did you do FLOT neo-adjuvant versus FLOT adjuvant? Do we have a study like that to say that FLOT neo-adjuvant is better than FLOT adjuvant, neo-adjuvant is better than adjuvant? Unfortunately, the answer is no. We have moved to neo-adjuvant slowly because of some reasons. For me, the most important reason to do neo-adjuvant therapy is that if you clearly accept that chemotherapy improves overall survival, and even in clinical trials, you find that half of all patients who undergo surgery don't end up getting the adjuvant part of the treatment. And if they're fit enough to take that treatment neo-adjuvant, you push it neo-adjuvant is for me the most important reason to do neo-adjuvant therapy, because all these neo-adjuvant studies have compared two different neo-adjuvant strategies. They have not compared a neo-adjuvant versus an adjuvant strategy. Have we clearly proven so far that the margin negative resections are better in one strategy compared to the other? No, because these trials have not been powered to say if you use FLOT, your margin negative resection is superior, statistically significant compared to if you do EOX. Numerically, it's better. So for me, the most important, micrometastasis is another story altogether. For me, two important reasons to do. One is that your patient has a 50% less chance of getting a life-saving therapy if you do surgery first. For me, that's the most important part. The second reason is, in the future, when you use more immune checkpoint inhibitors as part of perioperative treatments, these drugs are more effective when the tumor is in situ. Okay, there's a lot of studies from melanoma and other situations where they've compared neo-adjuvant versus adjuvant immune checkpoint inhibitors. The immune response that you get is much superior when you have the tumor in situ and then you're doing your immune checkpoint inhibitor versus not. Third is assessing biology and then adapting your adjuvant therapy based on response to neo-adjuvant therapy. We now do that in breast cancer routinely. If your patient has very good response to neo-adjuvant therapy, the way we manage them in the adjuvant phase is very different from somebody who does not have very good response. So I think it's more to do with feasibility, the ability of a patient to get a life-saving treatment, efficacy getting better in certain types of treatment when the tumor is in situ, and very importantly, doing risk-adapted therapy post-surgery based on what the responses to your neoadjuvant therapy was. I think these for me are very important compared to the question that you actually asked.
So Senthil sir, in which case you will advocate circulating tumor DNA?
It's experimental, so we'll leave it at that.